Hi, welcome to Shared Decision Making, helping families determine if newborn screening is right for them. My name is Gina Gerbath. I'm a CPM in Denver, Colorado, and I'm the Midwifery Department Chair at Midwives College of Utah.
I'm Yvonne Keller-Genther. I am a researcher at the Center for Public Health Innovation, and I work in newborn screening.
So, what is shared decision making? Shared decision making is kind of next in the evolution from informed consent into shared decision making. So, once upon a time, we were really focused on informed consent, which was a response to medical abuse and an ethical practice in the medical system. The focus was on protecting patients' rights, informing patients of, what the plan of care was going to be. There might have been some discussion of risks, benefits, and alternative options, but it was um, a pretty basic exploration of those options that patients had. So then we kind of progressed from informed consent into informed choice. And this was really a response to um, paternalism and lack of patient autonomy in the medical setting. It would provide multiple options to the patients. And the thought was also that the patients needed to get accurate, unbiased information. But it put the bulk of responsibility into client and patient hands without really helping them navigate a nuanced and complicated decision process. And so that's where we have kind of moved into shared decision making. And in the shared decision-making model, we have an emphasis on dialogue between the provider and the client, the midwife and the client, and really a discussion of what your options are, the risks, benefits, and alternatives, the provision of the accurate, unbiased information, and then the focus on personal values and preferences and the clinician's experience. So it's much more robust and it can be specifically tailored to each client as they make their decision. So there are some benefits of shared decision making. Shared decision making really fosters rapport between the provider and the client, as well as builds a relationship and builds trust between the client and the provider. It also builds health literacy because as the clients are going through this process, they are learning about the topic at hand. I would also say, kind of each one teach one, is that it also increases the health literacy of the topic at hand for the midwife as well. And then it validates that triad of what we consider to be evidence-informed practice, which is that we have research knowledge, we bring into it clinical experience, and then we have that focus on patient or client preferences and values.
So one of the tools that we've built, well, the tool that we built that we're talking about today is based on what's called the Ottawa Guide. And so what is the Ottawa Guide? So this came out of Ottawa, and they created this tool. It's used a lot in health, in a lot of different kind of healthcare decision making practices, and it's to help individuals with informed decisions about their um, health or social situations. So, a lot of medical providers use this when they're talking about things like stopping smoking, stopping other kinds of decisions that they have to make around behavior changes. Or social situations, or starting a behavior change, right? So it's not just stopping, it's starting a behavior change. It provides a structured approach for thoughtful discussion. It utilizes weighted options based on kind of your values and your knowledge. And so it's a decision maybe that might be hard to make. And then it enables individuals to kind of plan their next steps. And so it's very structured and helps individuals kind of go through thinking about what's important to them, what's important to their family, and helps them think through what they want to do. But it's a guide to be used with the health provider. So kind of what Gina just talked about, where it's not on their own. You don't give it to the client or the person to go away and make the decision. It's to help them have a structured conversation with their trusted healthcare provider. So it empowers individuals to actively participate in decisions that affect their lives. It ensures that the decisions are made, understanding what options are available to them, understanding the benefits and the risks, right? Because every decision has a benefit and a risk. But then it also brings into account their personal values, things that are important to them. And, there are a lot of sometimes competing personal values. And so kind of helps them think through what values maybe weigh more heavily, and helps them kind of think through those pieces in their decisions. And then it promotes a collaborative approach between the individuals and the healthcare professionals and their other support systems, right? Because a lot of people weigh in on those decisions for the families.
So now we're going to talk about the newborn screening decision tool that we have created together with a group of midwives, public health professionals, even honestly some kind of patient input too. So just, yeah, we've kind of created this tool that we want to bring to you so that you can use it in your practice.
Fine.
So why discuss this Ottawa Shared Personal Decision-Making Guide for newborn screening with families? Well, newborn screening is a complex decision. There's a lot of layers to it. There's a lot of individual circumstances to consider. And so it helps the clients navigate this complex decision. Also, there are many myths about newborn screening, both among even midwifery communities, families, certain populations. And so it's really important that we address these myths with the clients and declinations that when people are declining newborn screening, they might be making these declinations based on incorrect information. So it helps us to clarify the information for the clients. It's also an opportunity to provide education to clients. And again, that helps improve research literacy. And then it builds rapport, relationship, and confidence between midwife and client. And at the end of the day, it could save a baby's life. The end goal of the newborn screening decision-making process is for families to feel like they can make an informed decision that they're comfortable with for their family so that they can apply their personal preferences and values to the information that we're giving them to make the best decision for themselves.
So we're not looking for families to say they want to do the newborn screening. So it doesn't have to be a yes. It doesn't have to be a no. Obviously, as someone who's in newborn screening, I would love for families to want to do newborn screening. But at the end of the day, what you want is them to make an informed choice that they can be feel like comfortable with. So that's the goal. That's the goal of the tool is for families to feel like they have the information and they have information that's based in fact and that they can then make a decision that they're comfortable with no matter what the outcome. And so that's why the tool was created. And as Gina had said earlier, this tool was created. We brought together a group of people who are in the newborn screening community and midwives to come together to create this to figure out what could be done to help families have these conversations, and the decision was made to create this tool. So that's where this comes from. And so we're going to walk through each section of this tool with you, just so that you kind of have a sense of what the tool is and so that you can see, how the tool is built and how you can actually use the tool. So there's a lot of different versions of the guide. The guide that we're going over with you is a generic non-state specific guide. And the reason that I say that is because there are some differences between states in terms of some nuances in how they store newborn screening specimens. Most states they advise that you collect the specimen between 24 and 48 hours, but there's some variations in that too from the state. So you're going to need to visit your state to figure out kind of what their rules are. And some states are working on state specific guides. And so if you go to this website, the Center for Public Health Innovation, we will have all the state specific guides up. They're currently being worked on that have been created, that will be created. So we're working with states to do that. We'll have those up if they're being created, but regardless, you can use the generic version, and that will link you to national resources, which can link you then to state resources. The way that you're going to know which guide you're using is on the first page at the very bottom. It says this guide was made in collaboration with several state newborn screening programs and several midwives. If you have a state specific guide, A, it will be in the title of the guide, but B, at the statement at the bottom of the first page, if it's state specific, it'll say, and it's edited to reflect state name at the end. So North Dakota specifically is working on a guide with us right now, and Washington. We're hoping to get some other states going, but those are the ones that we know of at the time of this recording, which is in August. Oh, no, actually September of 2025. So we're hoping to do more, but that's where we're at right now. So let's start going over the guide. So the Ottawa guide is made in sections. And again, this is based on the Ottawa guide. So we took that guide and we followed it pretty closely. So section 1 is overview of the decision. So the overview is designed to provide some basic facts. That's the whole goal of the overview. And so what we have in our overview is we have the timeline that the screening needs to be done within 48 hours of birth. And that's just because that's the way that when they actually run the tests, they're designed for to meet that they're looking for indicators that would be present at that time, right? So that's why it's very specific. Those tests assume these indicators, these biological indicators within that 48 hours of birth. That newborn screening looks for conditions that have a treatment. Things aren't on the newborn screening panel that don't have a treatment, so they don't look for things that can't be treated. So that's important for families to know that. Newborn screening looks for conditions that are not evident by just looking at a baby and are harmful if not caught early. So specifically, things that are included on the newborn screen are things that you couldn't look at a baby and see, right? So often babies look healthy, and these are genetic conditions that you couldn't tell just by looking at them that they exist. The babies do look healthy, but you might not know that their bodies can't process the food. You might not know, right, that their muscles are deteriorating. So it's just hard to tell by looking at them. They look like normal, happy, healthy babies, and then things happen. So that's important. And then these are conditions that if they're not caught early and treated, they can be very harmful to babies. They can die. They can have cognitive impairments. It can be problematic. So that's why these are the conditions that have been added to the recommended uniform screening panel. There is a financial cost for newborn screening. That does vary from state to state. So that is something that would be important if you can figure out what that is for your states. So if you work with your state newborn screening program, they can answer what that cost would be for families. And it does change again from state to state. So that would be really helpful. Parents get to choose if they want to have their baby screened. That is a fact. So you should share that with the families and let them know that that is a choice that they get to make. And that the choice ideally has to be made before birth or right after birth because that screening has to be done within 48 hours of birth. So this is what that section actually looks like on the document. And this is, again, that generic version. And so it includes all that information that we just talked about. And then the section ends with asking where the family is with the choice. So have they thought about the choice? Are they thinking about it? Are they close to choosing? Have they made the choice, right? So if they've not thought about it, if they're thinking about it, they're close to choosing, then you continue on with section 2. If they've thought about the choice and they're comfortable with their choice, then you document that they prefer not to do the screening or that they have decided to do the screening, right? So if they don't want to do the screening, you would have them complete the needed paperwork for the state and for you. If they do want to do the screening, then that's great. Then you do whatever documentation you need to make sure that happens after the birth of the baby. If they don't do one of the first 3, then you would move on to section 2, which is called exploring your decision. So the explore section is designed to start the listing of reasons that they're considering for newborn screening and the reasons that they're hesitant about newborn screening. So the section is a place to list the considerations, to think about how much each one matters to the family. You start assigning weights and values to each of the considerations. And again, these are considerations for the newborn screening and considerations around hesitancy for the newborn screening. There's a place to think about who else might be part of this decision. So partners, other people that are important for the families that they might want to have weigh in. That might be you, that might be people outside of you and the family, right? So it might be parents, it might be friends, whatever, right? There's a place to think about if others are pressuring the parents, and maybe elicit a discussion about that. So maybe people outside who are important to them, but maybe they feel it's undue pressure and they don't know how to talk about that, right? So maybe you would be a safe person for them to talk about that pressure. And then there's a place to think about how others can support the parents. For example, share their views, stop sharing their views, help them find resources with the decision, help them pay for the screening, that type of thing. So here's what that section looks like. So at the top, it talks about, right, knowledge, values, and certainty. So below are the considerations around newborn screening. And then we've started a list, which I'll show you in a second. And then there's spaces for them to add to their own considerations to the list. They get to rate each consideration about how much each matters to them. And then they would choose the options with the benefits that matter most, right? So here's what that kind of looks like. So you've got two sections. You've got reasons to consider screening, and then they can rate on a scale of 1 to 5 how important or not important it is to them. And then reasons they might be hesitant about screening, right? And how important it is or isn't. And again, this list was made with our group that helped create the tool. So your newborn screening experts and your midwifery experts that were on our group. So we listed like peace of mind that the child was screened, identify that the child is at risk for having a treatable condition. Your child would be connected to early treatment that could decrease their chance of death or severe impairment. Even if other members in your family don't have a condition, it does not mean there's no risk. So those are reasons to consider screening. You may have to pay out of pocket for the screening. There's temporary pain and discomfort. Doing this may not fit with your personal beliefs. Most children won't have one of these conditions. So these are things that we've heard about, things that we've seen, reasons that we've heard. But again, there's room to add other reasons, right? What you'll notice is that we have an even number of reasons to consider screening and reasons to be hesitant. And so that's important. You'll also notice there's a total score at the bottom. These add up automatically. There's space for you to add reasons to consider. If the family has it, this is a fillable PDF that you can add reasons in part of your discussion, the shared decision making. Because you are comparing, you should have the same number of reasons for and reasons to be hesitant. So if you add a reason to be hesitant, you should also add a reason to consider. Just because then you're comparing apples and oranges when you look at your total score. So try to keep that in mind, that if you add one, you should also try to add something else so that your scores are more comparable. And then at the bottom of the section, you have 3 questions, right? Do you have an option you prefer? Do you want to do the screening? If so, you make a plan. Will the parent hold the baby on their shoulder while they gather the blood spot? Like if pain is an issue, right? Maybe that's a way to help with the touch. Will you be able to bill the insurance, right? To kind of help offset, right? So what's your plan for doing the screening and to maybe overcome some of the things that maybe you were nervous about? You don't do the screening. Okay, just make sure the family signing the paperwork that you need to show the state that they declined. Do you also want them to sign a declination sheet for your records, right? What do you need to show that you've had this conversation and they've made this choice? And then if they're unsure, well, then now you need to move on to section 3 and identify your decision-making needs. So the last part of the section is where you go over the support. So who else is involved? So this is a text box here where you can start to talk about, who else can help you think through this decision? Which option does this other group prefer, right? These other parties, right? Do they have something? Again, is there that conversation? Is someone pressuring you? That just kind of gives you a chance to have that conversation so that you can maybe help support them. Um, how can how can they support you, right? How can other people support you? How can others around support? How can you support them? And what role do you prefer in making the choice? Do you want to share the decision with someone else? Do you want to decide does the family want to decide for themselves after hearing the views of someone else? Do they want someone else to make that decision? So these are ways that you kind of go through that section 2 to help them think through all of those possible options. And then again, if you need to, you move on to section 3.
So section 3 is identifying your decision-making needs. And what it does is it kind of allows the client to quickly assess if they have the knowledge, that they understand the values that are most important to them, that they have the support and advice that they need, and how certain do they feel of their decision. And then it allows them to kind of score that and determine if they need any more clarification in any of those areas in order to make the decision about whether to do newborn screening or not. So this is what this looks like on the form. Identify your decision-making needs. Do you know the benefits and risks of each option? For values, the question is, are you clear about which benefits and risks matter most to you? So for example, one of the pre-filled in things might be not at all important to the client, and so they can just give that a very low score. Do you have enough support and advice that you need to make a choice? And do you feel sure about which is the best choice for you? And so if any of those answers are no, if they don't have the knowledge, value, support, or certainty that they need to make the decision, then they go back up to the previous step and work back through steps 2 through 4. And kind of focusing on what more information do they need in order to be able to make this decision. Let's see. So then moving on to section 4, you're going to plan the next step. Plan the next steps based on your needs. So this is going to be different for everybody. So if they needed more support from their partner, that's going to be what they're focusing on in this next step. So what they're going to do are brainstorm ways that they can get the information or support that they feel that they need. So if the answer is, I need more information about this, then the next step is to decide, how can we get this information for you? How can we help you get the information that you need? And this is what it looks like here. So this is sort of the plan, the plan of action for the next steps. So for example, I'll go into more detail. If it was a knowledge base, if they need more facts, you would give them perhaps you would give them more resources. You would go through the frequently asked questions. You could encourage them to talk to their pediatrician if they had questions about what this would look like down the road, that kind of thing. If it was about which values are more or less important to them, you could get them references for people that they could talk to, people with similar experiences. They could read stories or case studies from other people. They could also just talk about it. Like they could just maybe sit down and talk through it with you or somebody else. If it's in terms of, if they have needs in terms of what kind of support that they need, you could give them information about trusted providers or trusted resources. You could help them find other sources of support as well. And then if the answer is that they're feeling pressure, then you could help them focus on the views of the people who are more aligned with their preferences and value system. You could help them go through the guide again. You could encourage them to take this decision-making guide to somebody else, to another trusted advisor, and work through it with somebody else. Again, you're just helping them find resources, basically. And then if their uncertainty is, if they're still saying that they're uncertain about what they want to do, then you're kind of helping them go through the process again, until they feel like they have the knowledge and support and values clarification that they need to move forward.
And I know that there's a lot of sources out there on social media, and there's a lot of people who share their stories, and so that is not a bad resource. But there are also videos on newborn screening, state newborn screening websites, obviously of people who have had positive newborn screens and a lot of times have had diagnoses. And I guess I would say it would be nice to maybe share both of those. So you can share the people who are on social media who maybe had a positive newborn screen and it didn't end up being something, which you'll see those stories on social media. But it might also be worth sharing people who had a positive newborn screen and it did end up being something, just so families understand kind of both stories, that there's a chance of both of those outcomes. And again, not to pressure them, but just so that they understand the possibility of both. Uh, so just so they know at the end of the day, and they can be comfortable with either outcome. So the last section, and this section is different than the Ottawa Guide. So the Ottawa Guide doesn't typically have frequently asked questions and concerns around newborn screening, but this is something that our group really wanted to put out there. And this is kind of based on just what we were hearing and seeing when we looked at social media. And so this is the group put together the frequently asked questions and concerns around newborn screening. This was again created by our follow-up, right? It's people who worked in newborn screening, follow-up programs, midwives, and public health researchers. We went through and we looked at kind of what we were hearing out there, and we put in kind of common questions, what we heard, and then points to consider. And these do mostly, again, this is a generic version, generic, like not state specific version. Some of this will be state specific if you end up, if what your state makes their own version. But we have these common questions. So the diseases are rare, so why do you bother screening? And so we've answered those, right? So while they're rare, they can cause serious harm. We've got links to places that you can look for. So we have resources for you. For the non-state specific, those resources are national, which then tries to lead you to state-specific resources. We've got one of the frequently asked questions, we've never had children with these disorders before. And so we answered the question with most babies with these conditions are born into families with no history. We recently talked to a family where they had 5 children and their fifth child had a condition, but the other 4 did not, right? So these things come up and we were just trying to include those in the frequently asked questions. I don't want to hurt my baby. So we do actually in the frequently asked questions give suggestions that again were given to us by the midwives of ways to try to reduce the pain or make it easier for families. So that might be something to consider for families to consider if they decide they do want to have the newborn screen. I had genetic testing when I was pregnant, right? So prenatal testing is not the same as newborn screening. And so that gets answered in the answer to that frequently asked question. I know a lot of people are worried about states storing babies' blood spots. And so we do a link to states' rules. Again, when you have state specific, both the states that we're working with have a link to their specific rules. So that's something that can be really helpful. A common concern, right? Birth is a natural process. Our ancestors didn't need newborn screening. Why do we? This was really helpful. The midwives were very helpful in helping us come up with kind of answers to that question. They may not ring true for you, but these are answers that might be helpful for families, may not. I know vitamin K is something that people are worried about. And so if I choose not to do vitamin K, is it safe to do a newborn screen? And it is safe to do a newborn screen if you decline vitamin K. And then why do I need to have it at 24 to 48 hours after birth? Can I wait? And we explain that it really is better to do it at 24 to 48 hours after care. There are conditions that are on the newborn screen that children can die within 5 days of life. And so it is really, really important not to wait. And that is explained in there. So we have those in the tool. We are working on a prettier version because it's not very pretty right now. And working on it as a one pager. So if you're interested in just having this one page, that is coming, and you can go to the website, the Center for Public Health Innovation website, which we do have a link to at the end of this. If you just want to have that for your the families that you work with, you can have that. So that is an option as well. So let us know if that's something that you're interested in. And you can go again, I'll give you the link to the website.
Okay, another resource that we have available that we created together is the Did You Know tool. And the Did You Know tool is actually designed, it's targeting information for the midwives so that the midwives can answer clients' questions. So it's designed for midwives to use. Although honestly, clients can have the information too. But for midwives, we want to say, midwives, did you know that the ideal time to gather the blood spot newborn screen is between 24 and 48 hours after birth, regardless of feeding status? So whether they're breastfed or formula fed, that does not change the timing for the first screen. This, I will mention, there is some state variation. So check your state's guidelines. This might be different in some locations, but in general, 24 to 48 hours. We give some information in terms of collection technique. Some midwives recommend holding the baby up high on the shoulder so that we can use gravity to help the screen go a little bit faster. Some midwives prefer to have the baby nursing while they do it. So we are kind of giving some kind of positional techniques. One thing that came up when we were kind of looking into concerns in social media was that parents didn't like seeing that look of milking the foot or squeezing the baby's foot. And so making adjustments so that the parents don't have to watch that could be a helpful technique to incorporate. And then we have a table to give midwives more kind of concrete statistical information about newborn screening in particular, like specific information. So we give some statistics that newborn screening will detect rare but serious conditions. About 1 in every 300 to 500 babies will have one of the conditions of interest. We talk about the importance of timely treatment, that some of these conditions need intervention within days or weeks to prevent death or significant impairment. We want to explain that these screening tests are meant to prevent serious health outcomes such as intellectual disability, seizures, coma, or death. We want to provide reassurance that most babies are going to get normal results. Over 99% of babies are going to get normal results. So, it's not, again, this is not going to be something that most families are going to have to deal with. It is a fast and low risk process. It takes just a few drops of blood to test for a multitude of disorders, and that we want to provide clients that most affected babies, that these are unique to each individual baby, that even without a family history, that doesn't protect, that doesn't guarantee that this baby won't have one of these conditions. So, when we're talking about why families are hesitant to engage in newborn screening, a lot of times it is just because they want to avoid discomfort to the baby. So we want to provide reassurance that it is mild and short-lived. A lot of times clients have a hard time putting with the context of how rare these conditions are. There's approximately 2 to 3 per 1,000 that a baby will have one of these disorders, but that we want to make sure that they understand that the consequences of these conditions can be severe. And so, even though not very many babies are going to be affected, the babies that are affected can have severe consequences. We will talk a little bit with clients about the possibility of having a false positive. And so sometimes clients are hesitant because they don't want the anxiety that comes with having a false positive. About 1 to 2% of these positive results will actually not be true positives. And then again, one of the highlighted causes for concern right now is that parents are concerned about the specimen storage and privacy concerns. So every state has a different procedure for this. And if this is something that you're seeing a lot in your states, it would be worthwhile connecting with your newborn screening department to be able to answer specifically what the state, what your state does with the specimens after collection.
I will say that most states have a policy for how you can get your specimens returned. Like they're almost all states have, I think all states have a way that you can actually get it returned. So there is a procedure out there. You just need to call your states and figure out what that is.
Yeah.
So
And
and
then,
then
oh, sorry.
sorry, yeah. So we did include a section what you can do if you have a child who has an abnormal newborn screen, because I know that doesn't happen often. And so we just had this in here just in case. So if you have a child who has an abnormal newborn screen, usually often the newborn screening the state newborn screening program reaches out to you, lets you know there's an abnormal newborn screen, and then they do provide materials for you and for the family. And so that's you then can pass it on to the family. You will they'll have the family, it is a newborn screen, they'll tell you how to have the family get connected to diagnostic testing as quickly as possible. So they will work with you to get that family into diagnostic testing. If you're not the pediatrician, or they'll try to get you connected to a pediatrician. If you are the pediatrician or you're the one providing the services for the first few weeks, they'll have you try to do that. But they really want to get that family into diagnostic testing. They want to get them in, for blood work as quickly as possible. So they're going to work with you. But just know that they're going to be there for you. They are a resource for you, and they will give you education materials. But when it comes and that call comes, it can be a little frightening. And I know that they don't come very often, but they are there for you. There are resources for you. Baby's First Test is an awesome resource as well. And on this form is a link to that. They have resources for families and for providers on what to do. But, help the families. They're going to be nervous. Don't let them go down the Google rabbit hole. There are resources for them, written for them. And if you can give them those resources, that just helps kind of calm them down. So we just wanted to let you know that stuff is out there. It's out there for you and it's out there for them.
And just a quick, I think this can be helpful to kind of have this context for when you're talking to clients, but it is important to kind of clarify with clients that newborn screening, the blood spot screening, is a screening test and not a diagnostic test. And so having a little bit of understanding about the differences between those two types of tests can be helpful when clients have questions. And this goes back to the concern about false positives too. So a screening test shows who is at risk for the condition. It is it is not a diagnostic test. So when we say diagnostic, it's like who actually has the condition. But a screening test says who is more likely to have one of these conditions. And the thing about newborn screening is that there's so many conditions that they're checking for. And so this is an easier way to screen for multiple conditions. So it's more convenient to do this one blood spot screen than, for example, to diagnostically test every baby for all of the conditions that newborn screening is screening for. And then it's also less expensive. It would be very expensive to do diagnostic testing for all of the conditions of interest. So, but therefore we are kind of casting a wide net. We're putting it out there like who could be more likely to have one of these positive results, positive conditions, or be positive for one of these conditions. And you will sometimes get some false positives when you cast that wide net. But the trade-off is that then we're not doing this more involved, potentially more invasive diagnostic testing, and definitely more expensive testing for everybody. So we cast the wide net, we say, okay, which of these babies is more likely to have a condition? And then we select those babies for diagnostic testing. And then they move on through the process. So just being able to understand that we're not saying that we're going to definitively be able to say that your baby has one of these conditions with newborn screening, but we will be able to say which babies need to get diagnostic testing.
And I just want to say, as a field, newborn screening talks a lot about trying to strike that balance of not scaring families unnecessarily, but also not wanting to miss someone. And so, right, with every test, there's that, do you do a false positive or a false negative? And so the field really struggles with trying to make sure that a baby isn't missed, but also not wanting to have a lot of false positives. So just know that they're very concerned about not wanting to make families not wanting to have a false positive and having to put families through that trauma, but also not really wanting to have the trauma of missing someone. And so they'd rather err on the side of a few false positives versus missing someone. So I just want to put out there that that's why you have some false positives.
Right, right. And so one thing that our group did for this project in general was we really wanted to bring evidence-based information to you and wanted to give you good resources that you can take forward to your clients. But do know that some of these websites are subject to change. Sometimes the links, sometimes the direction changes, but sometimes the sites go down too. So really make sure that you're double checking the resources that you're sharing with clients, because sometimes they do change. But we really wanted, the Ottawa Shared Decision Making Guide in general is an evidence-based approach. We want the information that we're giving to clients and midwives to be evidence-based. So really wanted to come with references for you and for your clients. So we also created a consent and declination form. This is not a state-specific form. So this form is a form for your records. The intention is to kind of document that you did have this discussion, that you went through the shared decision-making process with clients, and to then be able to sort of show that the decision that the clients made following these discussions with the client. So it's for your records to show that you did your due diligence and really went through the process of making sure that your clients were well informed about newborn screening. It's not a state declination form. That is a different process. And potentially you might need to do both with your clients if somebody were to decline testing. At the end of the day, the idea is the client going to feel like they got the information that they needed, and we want to kind of show that we did our part to provide that information to the clients. So the form that we created is called the consent and declination form, and it still kind of summarizes everything again. So it summarizes what newborn screening is and explains that we would take a few drops of blood from the baby's foot and test for genetic, metabolic, hormonal, and blood disorders, and then explain that these are conditions that we might not be able to see just by looking at the baby, but rather we're doing the screening test so that they can get identified as quickly as possible and get the treatment that they need. We talk about that importance of early detection, that although these disorders are uncommon, they can be very serious. And so therefore, we want to have that early detection so that they can get treated as soon as possible and avoid some of the consequences from not treating these conditions that could happen. We explain a little bit about some of the conditions that are, I don't want to say necessarily more common, but the ones that people are more aware of. So we give a little bit of statistical information, incident information about some of the disorders. Congenital hypothyroidism, we talk about how it affects 1 in 2,000 to 1 in 4,000 newborns, and that it can lead to cognitive impairment, growth issues, and so that we can provide support so that these children can have better outcomes. PKU, I'll try to say it, phenylketonuria. I never know if I say it quite right. Urea, phenylketonuria. affects about 1 in 10,000 to 1 in 15,000 babies, and that it requires dietary treatment that without that treatment, this condition can cause intellectual disability. And so we can make those dietary interventions right away if needed. MCAD, medium chain. I'm actually not even going to try that one. Do you? Yeah. MCAD affects 1 in 10,000 to 1 in 20,000 babies. These babies can't break down certain fats for energy, and so therefore they need frequent feeding. They need to be eating frequently, and therefore we need to have really good lactation interventions, and making sure that they're getting the support and resources that they need as well. Severe combined immunodeficiency, SCID, is one of the more rare conditions, 1 in 58,000 births, but it is fatal without treatment. So these babies would eventually need a bone marrow transplant. So really, could be a dietary intervention all the way to a bone marrow transplant. There can be a wide range of treatments that are needed to provide protection from these conditions. And then you may recognize these frequently asked questions because we have brought them back from the frequently asked question tool. So you'll see that these are really the same questions, but we're just giving another opportunity for people to see them. Trying to see if there was anything different. I don't think there was on that page. And then this is where they would make the decision to either accept or decline newborn screening. At the end of the day, I don't necessarily want to practice defensive medicine, defensive midwifery, but if I had a client whose baby had one of these conditions, and I would want to be able to document that I provided the information that they needed to make an informed decision. And so for me, the form is really kind of like an affirmation that I did my job in providing good information to my client, because we all know that sometimes clients aren't necessarily processing all the information that we're giving them. It's a lot of information. And so kind of really going through this more deliberate process can provide a lot of assurance that we did do a good job of providing this shared decision making with the client.
One of the states that worked with us and the collaborative that built this had a midwife where a client did decline newborn screening and did end up having a child who did have a condition. And that family said that the midwife did not discuss newborn screening, but the midwife did have a history of having clients that did newborn screening. And so that's why this came up as something. So we did have an incident where this happened. And so this is why this decision was made to make a form like this. So yeah.
So if the client can say, okay, I'm still declining it, even with all this information. Again, here's the references and a recommendation to make sure that you're double checking the links because they are subject to change.
And then I'm next steps. So we're done with the education portion, and the next steps are really for you to take your evaluation. And then we also have links to the guide. So we will put these in the description below the video. So this is posted on YouTube. So we'll have links in the description, and we'll have links to the evaluation. The evaluation, once you do it at the end, there's going to be a link for you to get your certificate. So you should be able to do that. Yeah, so that's what you will need to actually get the information. And once you do the evaluation, you'll also have a link to my email in case something goes wrong. So thank you so much for taking the course. We really enjoyed being able to share this with you. We hope you find this useful. We hope this maybe helps you as you have these discussions with the families that you work with. And it helps you have those discussions and maybe makes them easier for you. So thank you so much for taking the time to take the course and to listen to us talk through it. And if you have feedback on the forums, you can also use the email. And if you go to the CPHI website, we're going to also have a form that you can give us feedback on the tools. We hope to improve them and make them better. But thank you so much for taking time to work with us today. Thank you.
Yeah, thanks everybody.